Hi, my name is Marian Ayad. I am a registered pharmacist and also a pharmacy student at the University of Colorado. Today we will be talking about low molecular weight heparin versus unfractioned heparin for venous thromboembolism prophylaxis. My presentation will be about 30 minutes long, and I will have a questions and answer session at the end for you guys to ask me any questions. Can you please introduce yourself for me?
My name is Mina. I'm a clinical pharmacist.
Hi, I'm Nadine. I'm a retail pharmacist.
Thank you. Why is VTE prophylaxis important? By providing proper prophylaxis for our patients, we reduce the risk of fatal and non-fatal pulmonary embolism and also post-thrombotic complications. I found some facts on the CDC website and some CDC statistics, and it was found that VTE is the leading cause of preventable hospital death in the US. Also, more than half of blood clots occurring in the outpatient setting after discharge are linked to recent hospitalization, which is a problem because it means that we are not providing proper prophylaxis for our patients in the hospital. They also stated that as many as 70 cases of VTE are preventable through prevention measure, yet fewer than half of these patients receive these. This is a figure from the CDC website. It says that blood clots affect as many as 900,000 Americans every year, and approximately 1 out of 10 of these patients end up having a blood clot-related death. It also says that 50% of the blood clots are healthcare associated, which means that most of those 50% of those people develop the blood clots after being recently hospitalized and after having surgery. Upon completion of this presentation today, you should be able to describe the pathophysiology of venous thromboembolism, identify common risk factors of VTE and assessment tools, list the patient population in need for VTE prophylaxis, list common therapy options used for VTE prophylaxis, compare both low molecular weight heparin and unfractioned heparin for VTE prophylaxis, and we will discuss a clinical study, summarize essential monitoring, evaluation, and patient education points. I will start by talking about the pathophysiology of VTE. In venous thromboembolism, the clot is manifested as deep vein thrombosis and/or pulmonary embolism. The fibrin clot is formed via the coagulation process. I will not go through this today, but I will briefly state the 3 phases that lead into that fibrin clot formation. The first phase is initiation, the second is called amplification, and the third is called propagation. How much do we know about deep vein thrombosis and pulmonary embolism? What is DVT? DVT, briefly, is the formation of a blood clot in a deep vein. Usually occurs in the legs, but it can also occur in other areas such as the pelvic area and the arms. Now, in some severe cases, a part of the blood clot can break away and travel through the bloodstream into the lungs. This is potentially life-threatening, and it is called pulmonary embolism. Some common warning signs of pulmonary embolism is shortness of breath, rapid breathing, increased heart rate, chest pain, and lightheadedness. Almost 2 million Americans are affected by DVT each year, and up to 600,000 are hospitalized due to DVT each year. Some common risk factors of venous thromboembolism is increasing age, previous history of VTE, aspects related to Vitreo's triad, such as immobility, patients that are hospitalized or have had surgery and haven't been moving for quite a long time, or people that are on long flights, for example. Obesity is another risk factor. Vascular injury, such as surgery, trauma, venous catheters. Hypercoagulability could also be a risk factor, such as malignancy. As we know, some certain drugs can also cause hypercoagulability, such as oral contraceptives and hormone replacement therapies. Coagulation factor abnormalities and antiphospholipid antibodies can also lead to hypercoagulability. We have so many assessment tools for venous thromboembolism, but I will only be discussing 2 of those today. The first one I would like to talk about would be the Padua prediction score. I came across a quasi-randomized control study that aimed to study the impact of using a Padua prediction score versus clinical judgment to provide venous thromboembolism prophylaxis in hospitalized patients. The study ended up concluding that there was a lower incidence of VTE in the group of patients that were assessed using the Padua prediction score versus clinical judgment because they received proper thromboprophylaxis. A Padua risk score of 4 or greater than 4 indicates a high risk of VTE. Calculating the Padua prediction score is pretty direct, as long as we have this list in front of us. We give the patient a score of 3 if he has active cancer, previous VTE, reduced mobility, already known thrombophilic conditions. We would give a score of 2 if the patient had a recent trauma and or surgery. We would give a score of 1 if the patient is 70 years or older, has a heart or respiratory failure, acute myocardial infarction or ischemic stroke, acute infection and or rheumatologic disorder, BMI of 30 or more, and ongoing hormonal treatment. Now, the second assessment tool I would like to talk about today would be the Caprini score for assessment. This was developed by Dr. Joseph Caprini, and he categorized it into very low risk, moderate, and high, with the very low risk score of 0. A score of 1 to 2 indicates low risk, with a score of 3 to 4 indicating moderate risk, and a score of greater than or equal to 5 indicating a high risk. Now, who needs VTE prophylaxis? How do we decide that the patient needs to receive VTE prophylaxis? I know we have many assessment tools, and sometimes we think that if the patient is high risk, then we should definitely provide prophylaxis, but this is not the case. Providing prophylaxis it really depends on the clinician, and he decides based on individual patient characteristics and risk factors. So not everyone with a high risk score would need to have VTE prophylaxis. We have so many therapy options for VTE prophylaxis. I will start by talking about some non-pharmacological options. The first option is early ambulation. The second would be graduated compression stockings, IPC devices, and inferior vena cava filters. Some common pharmacologic options would be unfractioned heparin, which we would be talking about today, low molecular weight heparin, such as enoxaparin, warfarin, aspirin, direct oral anticoagulants, such as dabigatran, rivaroxaban, apixaban, and edoxaban. Now let's start talking about low molecular weight versus unfractioned heparin for VTE prophylaxis. We will start by comparing them, and we will talk about a study called the PREVAIL study. This study was an open-label randomized study that aimed to study the safety and efficacy of using enoxaparin versus unfractioned heparin for the prevention of venous thromboembolism after an acute ischemic stroke. The patients were eligible to be enrolled in the study if they were 18 years or older, had an acute ischemic stroke confirmed by CT or MRI, unable to walk and assistant due to motor impairment with an NIHSS score greater than or equal to 2, onset of stroke symptoms within 48 hours before randomization. The exclusion criteria was pretty long, so I will just go through it with you. The patients were excluded from the study if they had VTE at screening or active bleeding, if they had a history of intracranial hemorrhage, heparin or enoxaparin-induced thrombocytopenia and or both, if they were hypersensitive to iodine, if they had spinal analgesia or lumbar puncture within the preceding 24 hours, if they had thrombolytic treatment within the preceding 24 hours, comatose at screening, known or suspected cerebral aneurysm, a confirmed malignant disease, impaired homeostasis, major surgery or trauma within the preceding 3 months, have been treated with low molecular weight or unfractioned heparin at a prophylactic dose for more than 48 hours before inclusion, have an allergy or hypersensitivity to heparin or enoxaparin, have bacterial endocarditis or a prosthetic heart valve, or if the patient has known or suspected severe anemia. Patients were also excluded if they had uncontrolled hypertension at randomization, which was defined as systolic blood pressure of greater than 180 and diastolic greater than 100. If the patient had a life expectancy of less than 3 months, they were also excluded from the study. If they participated in another study within the preceding 30 days. They had clinically relevant serious diseases such as severe liver disease or renal failure of a creatinine clearance of 30 milliliter per minute. And last, the female patients that are breastfeeding, pregnant, or could become pregnant during the study were also excluded. There were 2 patient groups. There was an enoxaparin group and an unfractioned heparin group. The patients in both groups received interventions within 48 hours of the stroke symptoms for about 10 days. The enoxaparin group received 40 milligrams subcutaneously every 12 hours, and the unfractioned heparin received 5,000 units subcutaneously every 12 hours. There were 2 outcome measures that were measured, primary outcome and secondary outcome. The primary outcome was defined as primary efficacy, which is the cumulative occurrence of VTE, and primary safety, which is 3 things: symptomatic intracranial hemorrhage, major extracranial hemorrhage, all-cause mortality up to 48 hours after treatment. The secondary outcome was defined as secondary efficacy and secondary safety, with the secondary efficacy being 5. Objectively verified symptomatic VTE, stroke recurrence, stroke progression, NIHSS scores, modified Rankin scale, and the secondary safety was minor extracranial hemorrhage, thrombocytopenia, and adverse events. I will not go through each and every primary and secondary outcome, but I will talk about the main points that are needed to conclude our conclusion today. The authors used a couple of statistical analyses in this study. They used a Cochran-Mantel-Hansel, Fisher's exact test, time to event analysis with Cox proportional hazards model, and a Kaplan-Meier analysis. I will not be discussing all these today, but I will talk briefly about the Kaplan-Meier analysis today. 1,762 patients were enrolled in the study, but only 1,213 completed the study, with 604 patients in the enoxaparin group and 609 patients in the unfractioned heparin group. what did the results show us? So when they came and measured the outcome, they found that there was a 43% relative risk reduction in the enoxaparin group compared with the unfractioned heparin group in the frequency of VTE. This was also maintained in day 30 and 60 and day 90. This table here is table 2 from the study. It talks about the incidence of venous thromboembolic events up to day 14 in the efficacy group. I'll just briefly go through some points. This shows us that there was a 43% reduction in all DVT in the enoxaparin group, and it was statistically significant. There was a 53% reduction of proximal DVT, and there was also an 83% reduction in pulmonary embolism, but this was not significant. It wasn't statistically significant. As we can see here, the p-value is 0.059. There was no difference between groups in the incidence of symptomatic VTE on day 14, 30, 60, and 90, as noted by the high p-values here. So, enoxaparin decreased the VTE occurrence, and there was no difference in incidence of symptomatic VTE between groups. This table here is table 3 from the study. It talks about the occurrence of VTE and DVT according to the NIHSS score. What is the NIHSS score? This is the National Institutes of Health Stroke Scale, and briefly what it does, it assesses the severity of the stroke in the patient. This is a very brief statement just to give you an idea of what the score tells us. So the higher the score, the more severe the stroke is. So this table basically showed us that there was a higher VTE occurrence in an NIHSS score of greater than or equal to 14. So VTE occurred higher in people that had more severe stroke. But it also shows us that the enoxaparin still decreased VTE occurrence in both people with a score less than 14 and people with a score greater than or equal to 14. In terms of safety, there was no difference between the enoxaparin and unfractioned heparin group in bleeding occurrence at the end of treatment, plus up to 48 hours afterwards. There was also no difference between groups in rate of mortality for any reasons other than VTE, stroke, or hemorrhage. There also was not a difference in the incidence of major extracranial the incidence of major extracranial hemorrhage was higher in the enoxaparin group. This table 5 here from the study discusses some of the safety outcomes that we talked about a second ago. Okay, my favorite part, the Kaplan-Meier survival analysis. This graph shows us the red line here is the enoxaparin group, and the blue line is the unfractioned heparin group. This, in summary, shows us that there was not a significant difference in survival rates between both groups in the study. Also, there was not a difference in the survival rate between the groups in people with an NIHSS score of less than 14. And as we can see here, there also was not a difference between survival rate in patients who have an NIHSS score greater than or equal to 14. Who do we think is the winner here? According to the study and the results, the authors concluded that enoxaparin wins. That is because it did show to have better clinical benefit to risk ratio. Also, enoxaparin is more convenient for our patients as it is administered only once daily. So it definitely is easier to have our patients adhere to treatment. As every study, this study had some limitations and some strengths. I will only discuss one of each. The main limitation that I found was that it was an open label study design, which means there could have been some bias of endpoints. The strength is that it is a randomized study, and we know that this is a strong type of study. So based on the results, I personally would recommend enoxaparin. I think it did show less, like a vast reduction in VTE occurrence between both groups. There also was not a difference in bleeding between both of the groups. And again, as I mentioned, as a retail pharmacist, I would definitely prepare something that is administered once daily and the patient can self-administer it easily versus something on fractional heparin, which would be dosed at multiple times a day. These are some monitoring key points. We'll have to monitor for platelet count, hematocrit, fecal occult blood, anti-10A levels, serum creatinine at baseline and during therapy, especially because we would have to adjust the dose of enoxaparin in patients with a creatinine clearance of less than 30 milliliter per minute. We'll also have to monitor for signs and symptoms of bleeding, and that is especially in our low-weight patients. Also observe obese patients with a BMI of greater than 30 kilogram per meter squared, and that is because the safety of enoxaparin in obese patients has not been well established yet. Some common side effects of enoxaparin would be bleeding, anemia, thrombocytopenia, fever, diarrhea, nausea, elevation of serum aminotransferase, injection site pain. Now, this is the most important thing, I believe, to let the patient know. Some contraindications would be active major bleeding, history of heparin-induced thrombocytopenia within the past 100 days, hypersensitivity to enoxaparin products, and hypersensitivity to pork or heparin. Some important counseling points would be to educate the patient on knowing what the signs and symptoms of bleeding are, or we would have to let them report right away if there's any unusual bleeding, bruising, or signs of thrombocytopenia. We also need to educate our patients on drug interactions. A lot of our patients think that since NSAIDs are over the counter, it's safe for them to just grab it from the shelf and take it regardless of what medication they are taking. So make sure we let them know, even if they don't tell us that they're taking NSAIDs, they might be on naproxen or ibuprofen. So we'd have to let them know that there's an increased risk of bleeding if taken with those drugs and if taken with antiplatelets and anticoagulants. Also, we would need to provide proper training and injection techniques for the self-administering patients, especially that a lot of them are afraid of administering injections to themselves. All right, and that is a wrap up. I will just go through a few summary key points that we talked about today. What is the pathophysiology of VTE? The clot formation is manifested as CVT and PE. The clot is formed via the coagulation cascade, and the three phases are initiation, amplification, and propagation. Some venous thromboembolism common risk factors include increasing age, obesity, immobility, pregnant woman, vascular injury, hypercoagulability. Some common pharmacological therapies for prophylaxis include the two drugs that we talked about, enoxaparin and fractional heparin. It also includes other low molecular weight heparins, direct oral anticoagulants, warfarin, aspirin. And then we also talked about the previous study, which was an open-label randomized study that compared both enoxaparin versus unfractioned heparin in terms of efficacy and safety for the prevention of venous thromboembolism after an acute ischemic stroke. The primary efficacy endpoint of the PREVAIL trial was the occurrence of confirmed VTE. Results of the trial found enoxaparin to significantly decrease the risk of VTE occurrence at day 14 compared with unfractioned heparin without any significant differences in occurrence of bleeding. Some summary of side effects would be bleeding, anemia, thrombocytopenia, and injection site pain. We would need to adjust the dose if the patient is obese, low weight patient, and if creatinine clearance is less than 30 milliliter per minute. These were some of my references that I used in the presentation. All right, and that's a wrap up. Thank you both for your time. I really appreciate it. Any questions for me today? No? Okay, thank you.